Okay, so we have different types of fixed prosthesis. The first one and the main one being indirect restorations. So with indirect restorations, these are restorations, as I've explained before, where the patient comes in, we prepare the tooth, we place a provisional restoration, then we send it off to the dental lab to be fabricated, or the dentist makes use of CAD/CAM technology to actually fabricate the restoration while the patient is still at the practice. Okay, so these are not placed immediately, as I've mentioned before. Can be a 2 appointment procedure where the patient gets a provisional one and then a final restoration, and then it can be fabricated in the dental lab, as I've mentioned before, and may be made using CAD/CAM material, CAD/CAM technology. So we can be making use of various materials, be it your full cast, your metals, your porcelains, or your acrylics, depending on the type of tooth that we are trying to repair. Okay, and then from there we go on to crowns. So crowns are basically anatomically contoured or shaped teeth that are fitted onto a tooth. So we basically use crowns in situations where the patient has lost a huge chunk of the tooth structure, so the normal resin or amalgam fillings just will not do. So there's not enough tooth structure to actually bond with the normal filling. So that's when basically we will be placing crowns. So it is anatomically shaped and fitted onto the tooth. As I said, it covers teeth with extensive decay as well as breakdown. So be it that it's severely carious or the tooth has undergone multiple fillings that just don't seat for a prolonged amount of time, or requires multiple restorations, that's when we'll place it. Or if maybe people such as who've undergone trauma or an accident where they lose a huge chunk of their tooth structure, then we'd rather just put a crown as opposed to normal resin material. So it is placed when there's no longer enough tooth structure to retain the filling. That's basically just what I said. So we prepare or the dentist prepares the tooth to actually allow or accommodate the crown. We can also then place a provisional, let it go to the lab, and then they bring a crown to us. So crowns can be done either with metal material, porcelains, or acrylics, as we had mentioned before. But the metal ones are normally placed posteriorly. Okay, then there's 3 types of crowns. So we have our full cast crowns that cover the entire coronal surface of a tooth. Then we have our partial crowns. So partial crowns cover like 3 or more surfaces of a tooth. So either MOD, OD, DO, O, or for example like a MODL. Then we have our partial crowns. So our partial crowns basically cover about 3 surfaces as well. So those are like the 3 types of crowns that we find in dentistry. Okay. So yeah, like I mentioned before, our full cast crown covering the entire coronal surface. Our partial crown, it covers 3 or more surfaces, but it leaves the facial surface intact. So the facial surface, but everything else is covered. And then so there are different types of materials that we can use. We can either have a metal crown, we can have a full porcelain crown, or a porcelain fused to metal crown. The difference in the 3 materials, ladies and gentlemen, not super important, but just general interest. It just depends on, let's say for example, like patient allergies and such considerations. Then the dentist will have to determine how much space there is, which determines which material we will be using, as well as financial how can I say this, financial obligations, if I can put it that way, because obviously a porcelain crown is more expensive than a metal crown. So if there are financial considerations for a patient, you would rather then maybe have a metal crown as opposed to a porcelain crown, especially if maybe we are covering the posterior teeth. So the three kinds, porcelain, metal, and porcelain fused to metal, differ in 1, the type of preparation the dentist has to do, and as well the amount of tooth structure that we may need to reduce. So if a patient lost so much structure, like let's say we're almost in the pulpal area of the tooth, it would not necessarily be advisable, for example, to put like porcelains, because porcelains require a lot of tooth removal in the preparation for it to actually seat, whereas a porcelain fused to metal ones, like let's say 1.5 millimeters of tooth structure removal for it to seat. So a porcelain would be like 2 millimeter tooth reduction. Porcelain fused to metal is 1.5 millimeter tooth reduction, whereas just a full metal crown, you can go for our 0.5 to 1 millimeter tooth reduction all across the board for the crown to actually be able to seat. So here on this slide are some examples of porcelain fused to metal crowns, as well as a full porcelain crown. But definitely where aesthetics are involved, like with our anterior teeth, we will definitely make use of full porcelain crowns. So posteriorly, where aesthetics are not such a big deal, but we're heavy on function and strength, we will then incorporate metal into those crowns. Okay, so then we have our 3/4 crowns, like we're saying, for example, with our partial cast crowns, where let's say we've lost 3 or more surfaces, but we're keeping the facial surface intact. That's when then we'll probably then make use of our 3/4 gold crowns. Né? So then we have inlays and onlays as cast restorations, or examples of cast restoration. So with inlays, basically, ladies and gentlemen, we are covering 3 or more surfaces. This is a restoration that is actually inside or within a tooth, so we can cover MOD, MODO, or just your occlusal surface. Okay, so this covers the area between the cusps in the middle of the tooth, as well as the proximal surfaces that may be involved and require restoration. So that's when we will be making use of an inlay. The only difference between an inlay and an onlay is that onlays, you will have to then include the cusp ridges of a tooth when you are preparing the tooth structure. So it includes the cusp ridges of a tooth. That's basically the big difference between inlays as well as onlays, but the materials remain the same. The material selection remains the same as I had highlighted before. Okay, so inlays and onlays. So gold onlay. So with this slide, we're at slide number 16. It's a gold onlay restoration on the mandibular first molar and a gold inlay restoration. So they're trying to just show you that with the onlays, the cusp ridges are also covered by the restoration, whereas with the inlay, we are basically covering within the tooth itself without the cusp ridges necessarily being involved. Né? So then, excuse me, we go on to bridges. Bridges are restorations that span a space of 1 or more missing teeth. So let's say here we have our 4-3, then we are missing a 4-4, then we have a 4-5. So basically that is the span. So a bridge is a prosthesis that covers the span of 1 or more teeth. So let's say now we've lost the 4-5 as well. So it will be 4-3, 4-4, 4-5, 4-6. So yeah, it's basically I could say a restoration that anchors onto abutment teeth to cover edentulous spaces. So a restoration that spans a space of 1 or more missing teeth, and it requires the coverage of 1 or more adjacent teeth. So there are types of bridges that, like a cantilever bridge, that require coverage or make use of just 1 tooth, but normally those are not as strong, or they have decreased strength, as opposed to ones that are covered by multiple abutment teeth. Okay, or 1 or 2 abutment teeth, or 2 or more abutment teeth, sorry. Yes, so bridges have components that you have to be aware of, please. So there are 2 components that form part of a bridge. So those are the abutments. So abutments are the tooth or teeth either on one or either side of the edentulous space that will help stabilize and support the fixed prosthesis, or the bridge in this instance. So like I said, yeah, teeth on either side of the missing tooth that provide support to which the fabricated tooth or the pontic can attach. So then the pontic is basically then the portion of the bridge that we are trying to replace or cover in our edentulous span. So that is the part of the bridge that replaces the missing tooth. Né? So pontics, you can find one of 2 pontics. You have your ovate pontics as well as your hygienic pontics. So with the ovate pontics, these are the pontics that cover the edentulous space all the way up to the gingival tissue, whereas the hygienic pontics are the ones that retain or keep a bit of space between the pontic and the gingival tissue. In that way, then it allows for the patient to make use of floss to actually keep that pontic and the fixed prosthesis nice and clean. Okay, so then bridges and abutments. So we have 3-unit bridges, 3-unit bridge abutments, points, and retainers. So we have a fixed bridge. So then this is when we make use of 2 abutment teeth that will then be prepared. We take our detailed impression, take it back to the lab, and then it brings back the prepared bridge, as well as then your porcelain fused to metal bridges. So then the 2 on the side, the metals on the 2 abutment teeth act as retainers to then keep the pontic as well as the abutments in place. Né? So those are the different types. And then for bridges, we also have Maryland bridges. So this is a type of bridge that does not require a lot of preparation. We normally prepare the lingual aspects of teeth on either side to replace an edentulous tooth that we have lost. This is mainly used in the anterior aspect or anteriorly, where there's not a lot of stress, and of course it then just costs a bit less for the patient while maintaining aesthetics and the function that we are actually looking for. So that's the nice thing with Maryland bridges. So normally we prepare and then we can place provisional restorations if necessary, but others come already with an edentulous area, so they don't mind going back home as they are, and then they'll just wait for the prosthesis to return. So that's the thing with Maryland bridges. And then the nice thing is with the abutment teeth on the other side, we can fabricate different sizes and types of abutment shapes that just ensure that the prosthesis sits well and it's very comfortable for the patient. So that's the nice thing then with Maryland bridges. Okay, ladies and gentlemen, then we have veneers. So veneers basically are a type of fixed prosthesis that covers much of the facial surface of a patient's tooth. Okay, so these can be used in instances where a patient has undergone tooth loss, such as with erosion, abrasion. They have staining on their natural teeth, such as patients that use medications such as tetracycline. So tetracycline causes like a bluish black staining of teeth, so that's when we'll then make use of veneers in situations like that, or when a tooth has undergone a fraction or has micro cracks, so we can correct them making use of veneers. We have three types of veneers. We have our direct resin veneers. So our direct resin veneers are basically veneers that can be fabricated in just one appointment. Now, they do not require lots of removal of tooth structure, so they are minimally invasive, and then they can be done in chair by making use of the resins at work, and then they can be light cured. So we get them, we prepare the tooth minimally, we place our resin, light cure it, and then voila, we have a veneer. Okay, so that is a direct veneer that requires just one appointment. And then from there we have our indirect resin veneers. So with the indirect resin veneers, these are veneers that are fabricated by the dental lab. So we are going to prepare the patient's teeth, more particularly the facial surface. We're going to take impressions of what we had prepared. We may or may not make use of provisional restorations. So the impression we then send off to the lab, which then they fabricate resin veneers, which then upon return we will place into the patient's mouth using cement. The problem with indirect resin cements is that they do not bond well with resin cements. They tend to be weaker or more brittle as opposed to our porcelain veneers, and they're not as strong compared to our porcelain veneers. And then lastly, as I've been mentioning, we then have our porcelain veneers. These are quite sensitive, if I can put it that way. They are very sensitive to the shades that you've selected. These also require 2 appointments, so they are fabricated by the lab. But the nice thing is, upon return, they are very natural looking, they're very durable and strong, as opposed to our indirect resin veneers. So also with the indirect resin veneers, with the direct resin veneers, we may have to use 2 types of composites to achieve this look. So we may start off initially with our body shade, and then we cure it, and then from there we then go to our incisal shade, then cure it, so it looks two-tonish, the same way our teeth look two-tonish. So the body shade we tend to use normally around the more dentinal surfaces or closer to our dentinal surfaces, and then on our outer surfaces then we will use the incisal shade or the body shade, which we can then just finish properly so that it contours with the rest of our teeth, and then we polish accordingly in that same appointment. So I think that was just something I forgot to mention with the direct resins. And the advantages of veneers, like I mentioned before, they are natural in appearance, all 3. It's just with the indirect resins, they don't stick as long as our porcelain veneers, and then from there they require minimal tooth reduction. So that is the one really nice advantage of veneers. So with veneers, basically this would be a patient, like we said, has staining of teeth, has undergone some tooth wear, or medications have stunted their smile, essentially. So, and then in other situations, we then have patients who have things like diastemas. So they want to just close spaces, like me right now. I have a diastema. So some people don't like their diastemas, unlike myself, and then they just want to cover that diastema. So we'll then just manipulate the material in such a way that we'll just add bulk on either side so that it actually closes up the diastemas or other spaces that we find in the oral cavity. So we can basically use it not only functionally, but mainly to improve aesthetics on the facial aspects of our anterior teeth. From there, ladies and gentlemen, we have the types of materials used in fixed prosthodontics. This is very important for you guys. So we have our alternate impression material. So before we actually start prepping teeth, we take impressions in the maxilla and the mandible using alternate. Those impressions we will be then using to help us fabricate a provisional restoration for the patient. And then we're also going to send them off to the lab once we're done fabricating our provisional restoration, so that the lab people can actually make a diagnostic costs using those impressions that we had done. Then from there, bite registration material, either polysiloxane or the wax sheets that we folded into our horse ridge shape. We then have our retraction cord. Our retraction cords come in different sizes. We were taught 2 techniques, so it's the double retraction cord technique or just the single one, but basically that's where a dentist uses a cord around the tooth, so that when they take an impression, or after removing the retraction cord, when they take the impression, the material flows in and around all that soft tissue, so that the technician can be able to better visualize the gingival margins that the dentist has then prepared for him for the fixed prosthesis. And then from there, we have our final impression material. We can use materials such as Improgum or our other elastomeric materials that flow nicely and give good detail, but we've covered those. I don't want to get into too much detail. We've covered all those materials last week, so those are the materials then we will make to get our detailed and definite materials that the lab people will then be using to fabricate our fixed prosthesis. Then we'll be making use of our temporary cement. So this will be then a cement that we use for to actually seat our provisional restoration. We have a bonding agent. So some people make use of like cements for the final restoration, or others just use bonding agents, like a longer technique to actually seat the prosthesis into place, as well as then the permanent cement. Like I'm saying, most people then use permanent cement to actually seat the prosthesis into the oral cavity. So you have to know those, and like 1 or 2 examples of each. I'm not going to get into those details because I think they're going to cover them in the lab, so please take note of those materials in the lab. And then for provisional restorations, which was not included in this slide number 22, would be materials such as snap. So snap was just a material, it acts like a polymer. So you mix, you place into the alternate, you place into the patient's mouth, you wait for it to set. When you remove it, it's going to take shape of the tooth as it was before you actually started preparing. But snap is not very aesthetic, so it's more ideal in the posterior aspects of your fixed prosthesis as opposed to anteriorly, okay? And then from there are different types of materials used for fixed prosthesis, but we're just going to cover those in 2 seconds.